Hello friends, my name is Dr. Santosh Abraham and I'm working as a specialist registrar in diabetes and endocrinology at Scarborough General Hospital. And today we are going to discuss about the Endocrine Society clinical guidelines on acromegaly. So the diagnosis, it is by measurement of IGF-1 levels in patients with typical clinical manifestations. In those without typical manifestations, but who have several of the associated conditions like sleep apnea syndrome, type 2 diabetes, arthritis, carpal tunnel syndrome, increased sweating or increased blood pressure. In those patients also the measurement of IGF-1 levels is warranted to rule out acromegaly. If you find a pituitary mass in routine imaging, then do an IGF-1 to rule out acromegaly in those patients. They don't recommend performing a random GH. And if the IGF-1 is elevated or equivocal, confirmation of the diagnosis is by finding lack of suppression of GH less than 1 microgram per liter following a documented hyperglycemia. So the GH in those patients will be over 1 microgram per liter after the glucose infusion or after the oral glucose load. So after the biochemical diagnosis of acromegaly is made, always do an MRI. So the MRI visualizes the tumor in detail, like the size and the appearance, as well as if there is any parasellar extent or extension. So it is the imaging modality of choice. CT is done when MRI is contraindicated. So if the tumor is found about the optic chiasm, do a formal visual testing, visual field testing also. So the management of comorbidities. So evaluate all patients for associated comorbidities. So this includes increased blood pressure, diabetes, cardiovascular disease, osteoarthritis and sleep apnea. They should be longitudinally monitored, that is over time, and rigorously managed, because otherwise the mortality will increase. And you do a colonoscopy at diagnosis to screen for colon neoplasia. And if there is a palpable thyroid nodularity, you do a thyroid ultrasound. And you also assess for hyperpituitarism, because there could be anterior pituitary hormone deficiencies in these patients, and the hormones should be replaced. So the goals of management. So a biochemical target goal of an age normalized serum IGF-1 value. So it shows the acromegaly is controlled. You could also use a random GH less than 1.0 microgram as a therapeutic goal, and it also correlates with the control of acromegaly. And it's important that you maintain the same GH and IGF-1 assay in the same patient throughout the management. So maintain the same assay. So it could be done with the IGF-1 or with the random GH. Surgery. So primary therapy is transperineal surgery. So if there is residual intracellular disease following initial surgery, a repeat surgery could be considered. So preoperative treatment and surgical debulking. So the Endocrine Society recommends against the routine use of preoperative medical therapy, which is intended to improve biochemical control after surgery. But with patients with having severe pharyngeal thickness and sleep apnea or high output cardiac failure, they suggest medical therapy with somatostatin receptor ligands or the somatostatin analogs preoperatively to reduce surgical risk from several comorbidities. So they don't recommend the use of pre-op medical therapy except in patients having comorbidities like high output failure, severe pharyngeal thickness and OSA. So to reduce the surgical risk from several comorbidities. So there could be anesthetic complications as well, so as to reduce this. Also in patients with parasellar disease, where a total surgical resection is unlikely, they suggest doing a surgical debulking to improve subsequent response to the medical therapy, that is to the to improve the response to the somatostatin analogs. Post-operatively, you measure an IGF-1 level and a random GH at 12 weeks or later. So after a glucose load, another GH level in a patient with a GH level more than 1 microgram per liter. Also do an MRI at 12 weeks after surgery. So do an IGF-1 level, do a random GH at 12 weeks, and do a MRI at least 12 weeks after the surgery. So it should be at least 12 weeks after the surgery. CT scan is done when the MRI is contraindicated. So what are the medical therapy indications for the medical therapy? One is persistent disease, which continues even after doing the surgery, with significant disease, like with moderate to severe signs and of GH excess, but without local mass effects. So you could use a somatostatin analog or pegvisomant as the initial adjuvant medical therapy. And also in patients with modest elevations of serum IGF-1 with mild signs and symptoms, a trial of dopamine agonists, usually carbogoline, is the initial starting therapy. So monitoring therapy, they don't recommend an ultrasound to monitor gallstones in a patient receiving somatostatin analogs. If the patient is on pegvisomant, it is important that serial imaging with MRI scan to evaluate the tumor size is done, because pegvisomant can cause an increase in the tumor size. Also, it could increase the LFTs. So LFTs monthly for the first 6 months and then every 6 months if on pegvisomant. Also, you can consider discontinuing pegvisomant if the transaminases are elevated more than 3-fold. So top up and monotherapy. So you could add pegvisomant or carbogoline with inadequate response to somatostatin analog. And it is used as a primary therapy if the acromegaly can't be cured by surgery, if the tumor has extensive cavernous sinus invasion, but it does not produce any chiasmal compression, and also if the patient is not a good candidate for surgery. So radiotherapy. So they suggest use of radiation therapy in the setting of residual tumor mass following surgery, so recurrence after surgery. If the medical therapy is unavailable, unsuccessful, or not tolerated, in those cases also you could use that. So use of SRT or stereotactic radiotherapy or conventional radiotherapy is preferred, but the conventional radiotherapy can be used if it is not available and there is significant tumor burden, or the tumor is too close to the optic chiasm, resulting in an exposure of more than 8 GYs. So CT, conventional radiotherapy, can be used if the SRT is not available, or if there is significant residual tumor burden, or if the tumor is too close to the optic chiasm. So monitoring radiotherapy. So every year you have to do the GH and IGF-1, and also titrate the medications along with that. Also annual hormonal testing, because patients on radiotherapy could become hypopit, and they could have other delayed radiation effects too. Special circumstances. In conditions where you have gigantism, the standard approaches as suggested in the guideline is followed. In pregnancy, stop long-acting somatostatin analogs and pegvisomant approximately 2 months before attempts to conceive. Use short-acting octreotide as necessary until conception. So in pregnancy, if the person becomes pregnant, or stop all medical therapy. So it's only for if the tumor is increasing, or if there is worsening headache, you give the medical therapy. Also, if the patient has a macroadenoma, serial VF testings has to be, visual field testing has to be done. Don't do a GH and IGF-1 during pregnancy, because they are meaningless. So digging deep, when we go more into the guidelines, so like what is the rationale behind all these guidelines, that's what we are going to discuss next. So why is IGF important? It is recommended as an initial screen because it is a marker of integrated GH secretion. So IGF-1 has a half-life of approximately 15 hours and the serum levels are relatively stable. But IGF-1 binding proteins extends the IGF-1 half-life significantly. So it could result in abnormal results for the IGF-1. So if the IGF-1 level is normal, it excludes acromegaly. But false positives can occur in pregnancy and late-stage adolescence. Also, falsely elevated normal or low IGF-1 can also be found in renal and as well as liver failure, hypothyroidism, malnutrition, severe infection, poorly controlled diabetes. The IGF-1 level decrease with age, so that is why the importance of IGF-1 with appropriate age-matched controls should be done. So all levels must be assessed in relation to age-appropriate normal values. So the single random GH measurements are not usually recommended because there is inherent episodic GH secretion from not normal and adenomatous pituitaries. So after 75 gram of oral glucose, if the GH level is less than 1 microgram per liter within 2 hours, it excludes the diagnosis. But increasing age, female gender, obesity and elevated BMI could be associated with abnormal post-glucose GH suppression. So many assays do not have sufficient accuracy at GH levels less than 1 microgram per liter. So that's why it is put as a cutoff of 1 microgram per liter, even though there is a possibility that in the future the level could be brought lower. So it is also important to measure glucose levels before and after the glucose load to verify that the hyperglycemia has been achieved, because in the absence of hyperglycemia the test is meaningless. So MRI will detect about 77% of macroadenomas. So MRI should be performed with 2 millimeter slices to diagnose small microadenomas. So GH secreting adenomas are characterized by hypo-intense T2 weighted MRI signal, and these have enhanced somatostatin analog responsiveness also. So if the MRI is contraindicated, you do a CT. So if there is a suspicion of ectopic disease, such as in a patient with biochemically confirmed acromegaly, but with a normal pituitary gland on MRI, so it is a diagnostic and a therapeutic dilemma. So the tumor could be microscopic and it could not be sufficiently visible on an MRI scan. Also, it could be due to an ectopic source of GH or GH. So somatostatin receptor scintigraphy, octreoscan, and thoracic and abdominal image may be considered to evaluate for ectopic disease. Colonic screening. So it should be kept in mind that it is difficult in acromegaly patients because the bowel may be redundant and tortuous, and there may be proximal colonic lesions as well. So a colonoscopy at diagnosis has been suggested. So repeat colonoscopy in every 5 years if they have a polyp or persistently elevated IGF-1 level. So every 5 years you have to repeat the colonoscopy if IGF-1 is elevated or you have polyp. And if the IGF-1 is normal and if there is no polyp, colonoscopy in every 10 years. So do not underestimate the thyroid, because thyroid cancer is one of the more commonly detected cancers in acromegaly, in addition to the colonic neoplasia. So there is a need for surveillance of thyroid disease in such patients. So examine the thyroid, palpate for any nodules. So acromegaly is associated with increase in thyroid volume and nodularity. So the longer the disease, the greater the number of nodules on palpation. So it's very important to palpate the thyroid. So arthritis and acromegaly. So they are frequent due to cartilage hypertrophy, tendon laxity, and osteophyte development. And finally, there will be joint destruction. So So early intervention with GH or IGF-1 control provides the best means to ameliorate arthropathy progression, but later stage will need physical therapy, analgesia, and joint replacement. So if you treat early, the joint complications will be lesser, and symptomatically the patient will be much better. Bone issues. So it is associated with an increased risk of vertebral compression fractures despite normal bone density. So this fracture risk could be accelerated by hypogonadism. So that's why gonadal steroid replacement is important here. And also hypogonadism could contribute to the loss of bone mineral density. There is also mandible and maxilla overgrowth. So it could lead to jaw malocclusion, which could be painful. So it might lead maxillofacial reconstruction. But it is important that until IGF or IGF-1 or GH levels are stable, there is no point in doing the reconstruction, because overgrowth may persist in the uncontrolled state. So even if you surgically correct it, if the GH and IGF-1 levels are still high, there could be the maxilla or mandible could still overgrow. So surgery, transpinodal surgery is the is a primary therapy. So there is no evidence of superiority over the endoscopic approach versus the microscopic approach. So both of them are found to be okay. So experience of the surgeon is a major determinant, and MDT is very important. That is a multidisciplinary team. And successful surgery, it will show that there is immediate lowering of GH levels, and also it provides tumor for microscopy as well. So you can also examine the tumor under the microscope. So that's why surgery is recommended as a primary therapy in most of the patients. So this is a brief chart about the management of acromegaly. So the first line is transpinodal surgery, and if there is remission, you do the annual IGF-1 and random GH, and then if there is any signs of recurrence, do an MRI. But if there's persistence of disease, then you could go with medications, somatostatin analogs for most, and if there is partial clinical and biochemical response to maximal doses, that's fine. Or consider combination with the SRLs, DAs, and pegvisament. But if it's still ineffective or no clinical and biochemical response, consider radiotherapy and consider the SRT. In patients who cannot be surgically resected because they are poor surgical candidates, surgical debulking could be thought before that, before giving medications, or they could be directly started on medications. Like if there's a mild disease, we can start with DA. For most of them, start with the SRL, and if it is not responsive, you could go with the pegvisament or a combination of all these things. And if it's ineffective, consider radiotherapy. So the success of transpinodal surgery, success remission rate is more than 85% in microadenomas and approximately 40 to 50% in macroadenomas. So if there is cavernous sinus invasion, that's very important. It indicates that tumor is not resectable. Also, there is an increased risk of anesthetic complications, including difficulty with intubation to laryngeal and pharyngeal soft tissue, and also vocal cord swelling. So it could result in sleep apnea syndrome. It may complicate both the pre-op and the post-op status of the patients and delay extubation. So treatment with the somatostatin analogs will reduce the soft tissue swelling rapidly. It will improve the sleep apnea and reduce intubation-related complications. So that's why in these patients, a pre-op somatostatin analog therapy could be considered. So the decline in IGF-1, since it has a long half-life, it is more delayed compared with the GH. and also it has got the IGF binding proteins also. So it should be only measured at least after 12 weeks after surgery. So it could produce a valid reflection of surgical remission. But if the IGF-1 level is still not normal, repeat IGF-1 level is needed. So a serum GH level of less than 0.4, sorry, it's not gram, it's microgram, less than 0.14 microgram per liter suggests surgical remission. And a level of less than 1 microgram per liter indicates control and normalization of the mortality risk. I apologize, it's a spelling error there. It's not gram per liter, it's microgram per liter. So less than 0.14 microgram per liter suggests surgical remission, and less than 1 microgram per liter suggests control. So it will decrease the mortality rate risk as well. So what is pegvisomant? So it is a human GH receptor antagonist. So it blocks peripheral production of IGF-1 by competing with the endogenous GH. So it does not target the GH secreting pituitary tumor. So the the GH hypersecretion persists during drug administration. So there is a chance that the adenoma will increase in size. So it is administered subcutaneously at 10, 20, 15 or 20, 10, 15 or 20 milligram daily injections. So in 95% of the patients receiving up to 40 milligram, IGF-1 was normalized in one study. But in another study, it was only achieved in 63% of the patients. So there could be a question why, or is pegvisomant really effective? So it is mainly attributed to the compliance issues as well as inadequate dose titration. So that could be the reason why in the second study the IGF-1 was only controlled at 63%. So when you take the when you put the patient on pegvisomant, you measure the IGF-1. So you don't measure the GH, because GH hypersecretion persists, and because of the interference of pegvisomant with the GH assays, you will never do the GH, but only with the IGF-1 you will monitor the drug therapy. So pegvisomant also exhibits a favorable benefit for glycemic control. So when comorbid diabetes mellitus is also present with acromegaly, so it is in opposite to the pasireotide, which could worsen the diabetes mellitus. So what about radiotherapy? So it could be considered in the setting of an aggressive tumor, especially with high Ki67 staining. So the radiotherapy could lead to biochemical control, so limiting the necessity of the lifelong medical therapy. That's the most important thing when you think about radiotherapy. But the full therapeutic effect may take many years, so and some of them will only have limited response. So medical therapy is required along with the radiotherapy when awaiting for the response. So stereotactic radiotherapy, it includes a number of modalities like gamma knife, cyber knife, and a linear accelerator. So the linear accelerator will use the high energy protons. So it could be delivered as a single dose like a gamma knife, or in a small number of fractions. So when you are doing the SRT, it is important to determine the tumor distance from the optic apparatus, because it is very important that the optic chiasma should be exposed to less than 8 GeV in order to reduce chiasmal damage. The optic chiasma could get damaged if exposures more than 8 GeV are used. So hypopituitarism occurs in more than 50% of patients within 5 to 10 years. So the prevalence with somatostatin analogs and with the conventional RT is almost the same in case of hyperpituitarism. So in conventional radiotherapy, there is an increased risk of cerebrovascular disease. So that is why we are preferring the SRT. Other complications are with the conventional RTs are radiation-induced cranial nerve damage, secondary tumors, radionecrosis, and cognitive changes. And radionecrosis is a rare complication of the gamma knife SRT as well. So because of the increased cerebrovascular risk and risk and other risks, we prefer SRT over the CRT, the conventional radiotherapy. So in pregnancy in patients with acromegaly, they will have autonomous GH secretion already, but then the placenta also will produce a variant of GH. So both normal pituitary and placental variant form will be found in the blood. So the conventional assays cannot distinguish between these two forms. And the GH is biologically active. The GH variant is also active and it stimulates IGF-1 production. So it will also raise the IGF-1 levels above the age-adjusted normal range. So there is no use in doing the GH or IGF-1 in pregnant patients. So you cannot monitor the disease in pregnant patients with IGF-1 or GH. Also, tumor growth and hemorrhage have been described during pregnancy. One patient had progressive visual loss also. So patients with acromegaly with macroadenomas should be monitored clinically for headaches and visual symptoms. The risk of gestational diabetes is modestly increased because of GH-induced insulin resistance. Cardiac disease has not been proved to be problematic, but gestational hypertension, the risk is also increased in those patients. So what about the use of somatostatin analogs and other drugs in during pregnancy? Why you are stopping these? Because it has been found to decrease the uterine arterial blood flow, and also probably IUGR, could result in IUGR. So octreotide binds to somatostatin receptors in the placenta. It crosses the placenta and it can affect the developing fetal tissues, which have a lot of somatostatin receptors, especially in the brain. So that's why we stop all the long-acting ones, and short-acting ones are used as and when required during pregnancy. Thank you.